Very good morning, everyone. Welcome to Masterclass, which is done by Indian Society of Gastroenterology. This is the 7th in the series of this Masterclass Series 2. And in this series, we are talking about the clinical cases, the important clinical cases which we see in our day-to-day clinical practice, and how best to approach them, how to interpret clinical signs, clinical symptoms, and how do you make a diagnosis based upon the clinical symptomatology and clinical features, and then what are the best diagnostic tests and how best you plan and treat an individual. So till now we have done 6 master classes, and this is a 7th in series, and this is again on very important topic, and this is acute pancreatitis and its complications. And I'm sure all of you see these patients almost every day coming to your casualty or in the outpatients. And how do you approach this patient is the topic for today's masterclass. For this masterclass, a couple of things are important to say, that here there Dr. Usha Datta, that's of PGI Chandigarh, is organizing a course on emergency in GI diseases. And this is a 2 days program, Saturday and Sunday. So they had a wonderful meeting yesterday. And today again, this meeting is going on. Even like to join after we finish masterclass, you can have 2 sessions on GI emergency, that's on liver emergency and luminal emergencies, which will continue after 1:30 once we finish our this masterclass. And here, all the residents from PGI and surrounding area are at one place, that's in Bhargav Auditorium of PGI Chandigarh, and they're joining us on this program. So welcome everyone on this masterclass. Let me introduce the faculty for today. We have Dr. Ganesh from Sri Ramchandra Hospital in Chennai. We have Dr. Praveer Rai. Praveer Rai is a professor of gastroenterology at SGPGI Lucknow. We have Dr. Sudipto. Dr. Sudipto Chaudhary is a professor at CMC Vellore. And we have Dr. Jayanta joining from PGI itself. And Dr. Jayanta is an associate professor of gastroenterology at PGI Chandigarh. We also have other faculty members like Dr. Usha is there, and I can see lot many people like Dr. Naresh Bhatt, Dr. S.V. Rana, and many of them are there in the audience. If you have any questions, this case is being presented from SRM Institute at Sri Ramchandra Institute at Chennai, and there are 2 trainees from there, Dr. Gautam and Dr. Vikrant. They will present the case. So please do send your questions on the chat box, and all the faculty will take these questions all along. I also need to introduce Dr. Pavan Rawal, who is sitting with Dr. Jayanto, and he will also be one of the moderators. To facilitate all this masterclass for today, we have Dr. Sridhar Sundaram. He's again associate professor of gastroenterology at Tata Medical Center or Tata Memorial Hospital in Mumbai. So he will coordinate the whole program for today. With this, I hand over to all the faculty to run this case. Dr. Ganesh, Dr. Sudipto, Dr. Praveer, and Jayanta, all yours.
Thank you so much, sir.
Good morning, everybody. Nice to meet all of you today morning. We are presenting a case from Ramchandra Institute of Medical Sciences, Porur, and we have one case of acute pancreatitis to be discussed by Dr. Vikrant and Dr. Gautam. Dr. Vikrant will deal with the history and clinical presentations, and Dr. Gautam will deal with the investigations and management. Over to Dr. Sridhar.
Thank you so much, sir. So I think we'll start with the history first. So I think Vikrant can take over.
Good morning, everyone. I'm presenting a case of a 52-year-old male who was admitted twice in our hospital in the month of April and August 2021 He's a 52-year-old male graduate businessman who came with the chief complaints of recurrent abdominal pain twice, once in the month of April and second in the month of August 2021, and fever for the past 4 days. Next. History of present illness. During the first admission, patient came with the chief complaints of upper abdominal pain of 2 days duration, which was sudden in onset, severe, deep pouring pain, which is causing the patient to writhe within in his bed, and it was radiating to the back, which was aggravated with food intake, relieved with medication, and on leaning forward. He also had nausea and vomiting in addition to the pain of 2 days duration, which was bilious, non-projectile, and immediately after food intake containing food particle without any blood. It was reduced or relieved with reducing the oral intake. For the above said complaints, he was admitted for a period of 10 days in the hospital, out of which the first 6 days was spent in the ICU. He also developed shortness of breath during the first admission, for which he required oxygen mask. He also had fever, chills, and rigors during the hospital stay, which relieved during the course of admission. He was kept NPO, treated with IV fluids and supportive care. He was told that he was having a problem with his pancreas, but no active intervention or endoscopic or surgery was done for him. He improved with supportive care and discharged with oral medication. On the follow-up period, he was on OPD follow-up. After a period of 1 month, he came to the OPD. He had significant improvement in the symptoms. All his symptoms were significantly decreased, but he had mild abdominal discomfort in the form of intermittent dull aching pain 2 to 3 times per week, which increased with food intake and lasted for a period of 1 hour. He did not have any nausea or vomiting, and his oral intake during the time was normal. A screening ultrasound was done 1 month after the discharge, during which time he noticed a small he was told that he was having a small pancreatic collection, but no intervention was done for the same. And the current admission was 4 months after the initial complaints, during which time the patient had 4 days history of pain. The character of pain was similar to the previous admission 4 months back, but on top of the pain abdomen, he also had fever of 4 days duration, which was high grade, intermittent, associated with the chills and rigors, but no other localizing features of the fever were present apart from the pain abdomen. His appetite was fairly normal, and he did not have any history of weight loss. He did not have any jaundice, abdominal distension, hematemesis, melena. There was no history of any trauma or recent drug use. His bowel movements are normal with normal stool consistency and color. His past history, he is not a diabetic or hypertensive. Prior to the past complaint 4 months back, he did not have any similar complaints before that. There is no history of any surgeries. He is not a smoker. He does not consume alcohol, and there is no history of IV drug abuse. His dietary history, his caloric requirement is 2,200 kilocalorie with 68 gram protein requirement, with a deficit of 300 kilocalorie and 20 gram of protein in dietary intake. His family history, none of his family members have had any similar complaints, and there is no history of any GA malignancies in his family members. He belonged to upper middle class modified Kuppuswamy scale. This is a brief summary of the timeline. During the first admission, that is in the month of April, the patient had pain abdomen, vomiting, nausea, for which he required ICU admission, following which he was discharged. He had minimal symptoms in the form of abdominal discomfort 2 to 3 times per week, and was told to have small correction, pancreatic collection 1 month after the initial admission. And the current admission is in the month of August, where he had pain abdomen, nausea. On top of that, he also had fever. Summarizing the history, a 52-year-old male who is a graduate teetotaler without any comorbidities presented with recurrent pain abdomen, probably of pancreatic origin. First episode of pain abdomen, vomiting, shortness of breath was 4 months back, which he required ICU admission, managed conservatively without any intervention. Discharged with oral medication, had minimal abdominal discomfort and small pancreatic collection during the 4 months follow-up period. And current admission, patient had pain abdomen. On top of that, he had fever with chills and rigors for a duration of 4 days.
Thank you, Vikrant, for the history. So we'll go on to the first poll question for the audience. I think if you can run the poll question. So what do you think is the differential diagnosis in this case? Is it acute pancreatitis with a local complication? If it's a recurrent acute pancreatitis, acute on chronic pancreatitis with a local complication, or if the diagnosis is something apart from any of this?
Sure. So can I come in? Sridhar, hi. Hi. So as you put up those questions, just to ask Vikrant. Vikrant, wonderful presentation, and thanks for this. Just to ask you, how would you define recurrent acute pancreatitis?
So recurrent acute pancreatitis is defined as 2 episodes of acute pancreatitis with an interval of at least 3 months in between, with no evidence of any chronic pancreatitis or peripancreatic fluid collections.
Right. So as you know, there have been different definitions of recurrent acute pancreatitis per se. The one of these definitions is from the INSPIRE group, which has said that if you have 2 episodes of pancreatitis more than 1 month apart with complete resolution of pain in between, or there is another definition from the INSPIRE group which says 2 episodes of pancreatitis without any time interval, but where the amylase lipase completely normalizes between the 2 episodes. But then now we are looking at more of a mechanistic definition of recurrent acute pancreatitis, where the morphological changes are not more important. What we're looking at, what the definition is a syndrome of multiple distinct acute inflammatory responses originating within the pancreas in individuals who have either genetic, environmental, traumatic, or morphological risk factors, and where the episodes are separated by at least 3 months. So there are differences as regards the definition of recurrent acute pancreatitis as their time is concerned, and probably because we really don't know the time frame at which pancreas really recovers.
Okay. Thank you, sir. So I'll be sharing the results of the poll. So 64% of the audience actually feels this is acute pancreatitis with a local complication. 18% felt it is recurrent acute pancreatitis. 16% felt it was acute on chronic pancreatitis with a local complication. So just a brief discussion on just one second. So severity grading in acute pancreatitis is something that we should be knowing as part of routine clinical practice, because most of our patients have to be prognosticated, and based on severity grading, we should be able to say how severe the pancreatitis is. So there have been different classifications that have been given over a period of time. Initially in 92, the Atlanta classification came in, but the terminologies were not very clear. Subsequently, there was a revised Atlanta classification that was given in 2013, which is what we follow at the moment. So you can see that the revised Atlanta classifies it into mild, moderately severe, and severe acute pancreatitis. This is what is practiced routinely in clinical practice by most people, and also in various clinical trials. The revised Atlanta also gave classification for peripancreatic fluid collections. They divided it into 4 types: acute peripancreatic fluid collections, or pseudocyst, in case of interstitial edematous pancreatitis, and in case of necrotizing pancreatitis into acute necrotic collections and walled off necrosis. Now, management is largely dependent on these terminologies also, so which is why it is something that we should be aware of. Coming to the next poll question, how is organ failure defined in patients with acute pancreatitis?
Sridhar, can we just hold on for a minute?
Okay.
So I think, Vikrant, can you come to the summary of the history? Because I think we have first year, second year DM residents as well.
Should I go back, sir?
Yeah, please.
Yeah, I'll do that.
Yeah. So, Vikrant, I think we have totally surrendered ourselves to a definite diagnosis. But before we do that, can you just tell me what makes you think of this particular diagnosis, which 65% of the students have agreed to? So, you need to analyze the symptoms that you have put forward in the history. Moreover, there are certain things I think which we need to know more about the history in which you have presented. So can you analyze the symptoms, Vikrant?
Sir, yes, sir. Sir, the patient had pain suggestive of pancreatic pain 4 months back, for which he required ICU admission for a period of 6 days and a total hospital stay of 10 days, indicating the patient had significant pancreatic pathology during his first admission. And during the period of follow-up for a period of 4 months, the patient has not been completely asymptomatic. He did have mild symptoms in between for the past 4 months. And he also was told that he had some amount of peripancreatic collection, indicating that the acute event which has occurred 4 months back may not have been completely resolved, and there is some amount of damage which is persisting in the present patient, which might have aggravated during the current admission, during the recent admission, either due to infection or any other secondary precipitating event causing the second admission.
Yeah, I think the point that I'm trying to make is based on history. You have certain very, very important features to suggest that this is possibly pancreatitis, and the other differential is quite less in this particular case. So, typical pain in the upper abdomen, radiation to the back, persisted for around 2 days period, severe pain. So, which possibly suggests that it's not alone a biliary colic, but possibly related to pancreas. So, in biliary colic, you have pain persisting for less than 6 hours, which is not the case in this particular scenario where you had pain persisting for 2 days in the prior admission. So this suggests that possibly pancreas is in play. Moreover, you had an imaging which suggested a collection. So what you're assuming is possibly a moderately severe pancreatitis. Okay, so if you are thinking of, based on this, if you are thinking of moderately severe pancreatitis or pancreatitis, so I think it's very important to take a drug history. So there are many, many drugs, commonly used drugs, which are known to cause pancreatitis. So it's very important to know these drugs. I think we have at least 30 drugs which have established relationship with pancreatitis, and more than 300 drugs which are known to have possibly play a role in acute pancreatitis. So some commonly used drugs that you can have causing pancreatitis may be tetracycline, maybe carbamazepine, valproate, isoniazid. So these drug history becomes very, very important to know, if because this patient what you presented is possibly not an alcoholic. So these history become very relevant. Sridhar, you can carry on with your poll now.
Thank you, sir. Okay, so how is organ failure defined in patients with acute pancreatitis? So is it the Ranson criteria, Apache score, BICEP score, or the modified Marshall score? Okay, so 65% said it's the modified Marshall score, 17% felt it was the Apache score, 10% felt it was the Ranson criteria, and 7% felt it was the BICEP score. So the correct answer is modified Marshall score is used for severe organ failure in as per the revised Atlanta classification. This is something that again we use routinely in clinical practice, and everyone should be aware. So I have one last question before we go on to the discussion. So what proportion of patients progress to chronic pancreatitis after an index episode of acute pancreatitis? Okay, so 37% felt it was 10%, 28% felt 15%, and 25% felt it was 5%. So the answer is 10%. So there is a meta-analysis of 14 studies published in gastroenterology in 2015, almost 8,400 patients. So recurrence after an index episode was to the tune of 22%. Chronic pancreatitis is seen in 10% after a single episode. And in 36% after recurrent episodes, then smoking, alcohol, and male gender were associated with higher risk of progression. Now, there is one Indian study from Western India with 97 patients of acute pancreatitis. They found that 27% developed recurrence over a median follow-up of 32 months, and 18.6% in that study had evidence of chronic pancreatitis on follow-up. So this is for the Indian data.
Just to add to it, Sridhar, we did look at that, and we found that with each episode of pancreatitis, when we looked at the degree of stiffness or fibrosis in the pancreas, in our study, we found that with each episode of pancreatitis, there's an incremental evidence of stiffness or fibrosis within the pancreatic parenchyma, going on to show that every episode of pancreatitis only leads to further fibrosis and progression towards chronic pancreatitis. So it is just common sense to say that every episode will only lead on to further chronic pancreatitis, and a single episode of severe pancreatitis can lead on to chronic pancreatitis, or what we call as the sentinel acute pancreatitis event. So having said this, if a person has a severe pancreatitis at the start of it, where almost the entire pancreas melts away, possibly that person can go on to develop exocrine insufficiency in the long run.
Yeah. Sudipto sir, I'd like to just chip in over here. Regarding this part of whether a single attack of pancreatitis can lead to chronicity or not, I guess if we see all these results that, all this data that Sridhar has pointed out, probably the crux of the issue that the residents should understand is that a single episode of, let's say, a gallstone pancreatitis need not lead to a chronic pancreatitis. Until unless it's a very massive kind of pancreatitis destroying the whole of the pancreatitis, which we earlier used to read in our textbooks as something called as complete damage of the pancreas with obstruction of the pancreatic duct leading to this chronicity. Other than that, if you see the risk factors for development of chronicity are smoking, alcohol, etc. So basically, probably the first attack of pancreatitis was the harbinger of a disease process or pathogenesis that will go on for the next few years to eventually lead this patient to chronic pancreatitis. I think that is the whole pathogenic mechanism that must be going on at the back.
Until and unless the pancreas melts away completely at the first episode itself, unlikely that the person will go on to develop chronic pancreatitis.
Absolutely.
Yeah,
Okay,
so one more point that I would like to make here is that once you have a treatable cause like biliary pancreatitis, so mild pancreatitis patient is admitted. So in these patients, obviously, if you leave these patients, these will have another episode, say around 8 to 10% within a period of 40 days. Suppose there is a bile duct stone which has been not if there is a gallstone disease and you don't intervene, don't do a cholecystectomy at the time of admission, then there is a risk of around 8 to 10% within a period of 40 days. So these patients should, obviously with mild pancreatitis, these patients should undergo early cholecystectomy rather than leaving gallbladder in situ.
So Praveen sir, to this point, I'd like to ask one question to you as well as Dr. Sudipto sir. Is that, do you believe that, let's say a gallstone related pancreatitis is there, a patient develops the first attack, you do not do a cholecystectomy, the patient develops a second or a third attack, let's say, in a span of a 1 year or 1.5 years, does this group of cohort of rare patients, definitely rare cohort, but will they eventually develop chronicity? Because as Sudipto sir has highlighted that with every attack of pancreatitis, the fibrosis or the stiffness of the pancreas kept on increasing according to his study.
Yeah, so I think it's very obvious that recurrent episodes of pancreatitis due to any cause will lead to chronicity for sure. So the point that I'm trying to make is that if you have some treatable cause, especially gallstones, these should not be left. So if you read the literature, especially in gallstone disease, the risk of pancreatitis, recurrent pancreatitis increases over time. So these patients should undergo, if it's mild disease, within the same admission, they should undergo cholecystectomy. If they have moderate or severe pancreatitis, moderate pancreatitis maybe after 2 to 4 weeks after getting a suitable imaging, maybe a CT scan or MR, when we don't have any evidence of large collections or less of inflammation, so that the patient can undergo a safe cholecystectomy.
Absolutely.
Yeah,
Having said this, Swanta, sorry to chip in again. Sorry, this discussion probably will continue a little bit more, Sridhar. But to just chip in here, we have to discriminate two entities again. One is where there's an obvious gallstone, and other when we are talking about microlithasis.
Right, sir.
When you're talking of microlithiasis, the story becomes slightly much more complicated. Now, if you look at Dr. Garg's study, which came out in 2007, including 75 patients of gallstone pancreatitis, 50% actually went on to develop chronic pancreatitis despite having had a cholecystectomy done. Sajid study done from our center went on to show that almost 25% went on to develop chronic pancreatitis. Having said this, what it means to say is that what we don't know here is that whether microlithiasis is a subset of patients who already, because of recurrent episodes, had developed chronic pancreatitis in the long term. So these are some unanswered questions here, which we don't want to confuse the residents with. But what we want to say is that when there's obvious gallstones, we should go ahead with cholecystectomy as soon as possible.
Okay. So I think Vikrant can again take over. This is
With the above said history, I would like to consider the syndromic diagnosis of recurrent upper abdominal pain, probably of pancreatic origin, which is complicated by the fever. The differential diagnosis in the above said case, I will first consider as a sentinel event which has occurred 4 months back, which persisted and causing local complications of infected pancreatic pseudocyst or wall of necrosis. My second differential is recurrent acute pancreatitis with local complication. Since the patient had some amount of collection on the follow-up ultrasound after 1 month. And the final, down the list, I would like to consider acute on chronic pancreatitis with local complications, since the patient did not have any history of significant weight loss or prior abdominal pain or steatorrhea. Coming to the etiology, the patient did not have any obvious insults which causes the pancreatitis for him. Since gallstone related is one of the most common cause of pancreatitis, I would like to consider gallstone related pancreatitis. Considering he is greater than 50 years old with the first episode of pancreatitis, we should probably also consider malignancy as one of the etiology.
So I think Vikrant, at this point of time, you could have well mentioned in the diagnosis about which month of pancreatitis, from the onset of pancreatitis, what is the total duration. So that again tells you, because there is a treatment modalities in first week, second week, third week, or beyond may be a bit different. So approximately what days, like this possibly is around 4 months from the onset of pancreatitis. And
Yes.
instead of mentioning about, see, this walled of pancreatic necrosis may be an imaging diagnosis. This is not a clinical diagnosis. So what you can mention is an infected pancreatic fluid collection, because this is what you had in imaging. So necrosis, whether it's present or not, can only be determined on imaging like CT scan or MR. Without that, what you can say is an infected pancreatic fluid collection. So that would be better. So I think we can further go ahead on this.
go ahead with the examination.
I think so. We have already exhausted around 25 minutes.
Okay, sir. Yeah.
On general examination, he is conscious, coherent, oriented to time, place, and person. There is no signs of any nutritional deficiency. There is no pallor, icterus, clubbing, cyanosis, lymphadenopathy, pedal edema. Oral cavity examination is normal. On vitals examination, his blood pressure is normal. He is having tachycardia with a pulse rate of 106, respiratory rate, tachypnea with a rate of 22. He is febrile with a temperature of 101 degrees Fahrenheit. His oxygen saturation is normal. The patient is currently in SIRS. His anthropometry, his height, weight, and his BMI is appropriate. On abdominal examination, his perabdomen is flat. A palpable lump of size 4 into 5 centimeter is noted in the epigastrium 3 centimeter below the xiphoid process. With a smooth surface, the borders of the mass are ill-defined. The mass is tender to touch, and it is not moving with respiration. It is becoming less prominent on leg rise. The features were suggestive of a retroperitoneal mass without any intrinsic mobility. His liver span is normal. His spleen is no splenomegaly. Top space is resonant. No free fluid in the abdomen. Bowel sounds are normal. Rectal examination is normal. Other system examination, respiratory, cardiovascular, and CNS were within normal limits.
Yeah, so Vikrant, I think what you need to describe here further is, you mentioned about it being a retroperitoneal lump. So what I need to know from you, how do you differentiate between a retroperitoneal and an intraperitoneal lump?
Peritoneal mass.
Sir, retroperitoneal mass, the borders are not well defined and it does not move with the respiration. And on forward stooping, the mass does not become more prominent, and there's no internal mobility of the retroperitoneal mass.
So any other important point? Okay, so what is ballotment and bimanual palpation?
So ballotability is on placing one hand in the back of the patient and giving certain pressures so that the other hand, which is present on the anterior abdominal wall, the hand will palpate the mass moving. And the bimanual palpation is a simultaneous palpation of the mass using both hands. Both hands, the mass will be palpable.
So what does that indicate?
It indicates ballotability is generally seen with renal mass, sir.
Yeah, so I think it's very important when you are trying to differentiate between a retroperitoneal and intraperitoneal lump. You should mention, like you come to the prior slide, you should mention all the features in the same go. So don't give room for the questions here. So I think all differentiation between the retroperitoneal and intraperitoneal lump should come straight away, including its ballotment, whether it's present or not, bimanually it's palpable or not. So that should come in the same go.
Yes.
Yeah, so based on this, you have anything to add in the examination here about the abdominal lump?
No, ballotability and bimanual palpation, sir. Other than that,
Anything else you would like to add to it?
sir, presence of any abdominal lymph nodes in the periumbilical region or any
So what do you think this lump is?
sir, pancreatic fluid collection, sir. Since it is retroperitoneal and also patient had the history of feature suggest of pancreatitis, the most likely cause is a peripancreatic fluid collection.
So you do have any differential, or do you think this is clear-cut peripancreatic fluid collection, what you are seeing?
So this is a mass which is in the epigastrium, right?
Yes, sir.
And this is a fairly large size mass, 3 centimeters below the xiphoid process with a smooth mass. So it sounds like more. Sorry, it's a bit of an echo going on. Hello? Yeah, sorry.
We can hear you. We can hear you.
You can go ahead, Sudipto. We can hear you.
Yeah. No, I was just trying to summarize that this, yeah, based on the history, it does sound like an. It does sound like a what? I'm sorry, I'll just mute myself. I think there's a problem.
So Vikrant, so the point that I'm trying to make, since on history you are thinking in the terms of pancreatitis, that's the reason possibly you have made this as a pancreatic fluid collection as the first possibility. Can you tell me at this particular site, what are the other lumps that you can have in this particular site?
Epigastric region, the contents are stomach, sir, and the antral region, duodenum can be a content, and aorta is a content in the epigastric region, sir. And pancreas. In pancreas, we can have pseudocyst or wall of necrosis, peripancreatic fluid collection, and in case of CH, stomach could be one of the differential in the epigastric region mass, sir. And also aortic aneurysm is a differential of epigastric mass.
What about left
And
lobe of the liver?
sometimes you can get a lymph nodal mass out there also, right?
Yes, sir.
You can get a large conglomerate of lymph nodes out there, and retroperitoneal masses too.
Yes.
So
like a retroperitoneal sarcomas, etc.
The lymph node masses, the aorta, stomach, left lobe of the liver, besides the pancreatic fluid collections which you can have. So these are the contents which you can have in the epigastrium.
So
okay.
Easier way to remember the masses is to just divide the 9 quadrants and imagine the structures which lie in the 9 quadrants, and then relate the masses which can arise from those structures in the respective quadrants.
Probably we have to.
We move on, Sridhar.
Okay, sir. So I have 2 more poll questions before we go ahead. What is the risk of heavy alcohol drink, that is more than 5 per day, developing pancreatitis? Yogit, if you can run the poll, please. Thank you. So the options are 3%, 13%, 23%, and 33%. Okay, so majority people, 44% answered 13%, 25% felt it was 3%, and 20% felt it was 23%. So the answer is 3%. This is a study, a longitudinal study from Denmark, which had almost, which was actually a study taken from the Danish heart study. And they had a large cohort of patients, and they followed them up, and they found that the risk of acute pancreatitis is 1.6% among heavy then chronic pancreatitis was 1.6%. Okay. So alcohol is the second most common cause of acute pancreatitis after gallstones. So we know that it is associated with fatty acid ethyl esters and associated with increased progression to chronic pancreatitis. So there is a monotonic and possibly exponential dose response relationship, and a threshold of around 4 drinks per day is what is considered risk drinking with respect to pancreatitis. Coming to the last poll question, what proportion of patients with acute pancreatitis develop pseudocysts? 10, 30, 50, and 70%. Okay, so the majority, 57% have answered 10%, 30% felt it was, 41% felt it was 30%. So the correct answer is 10%. It's in the range of 5 to 16%. It's an old study. Even after this, whatever studies have come, even a meta-analysis actually said it was 10%. So coming to the final diagnosis, and I think Vikrant and Gautam can take over.
I think before Vikrant, you comment on final diagnosis, I'd just like to add a point here. So as you saw that only 3% of the patients who take alcohol develop pancreatitis. So what one needs to remember is that there are other very, very important factors which are associated, which increase the risk of pancreatitis in alcoholics. Especially smoking has been found to be a very important risk factor. So those who smoke, some genetic factors are involved, and some dietary factors also play a role in causing this pancreatitis. Go ahead, Vikrant.
Add a bit to it, Dr. Praveer. 2 recent meta-analyses have actually shown that smoking as an independent risk factor for development of acute pancreatitis. So not only is it a contributor to alcoholic, smoking on its own has an independent risk factor for development of chronic acute pancreatitis. And the risk is because nicotine somehow tends to decrease the blood flow within the pancreas and increases the calcium levels within the pancreas and leads to activation of zymogens. So yeah, smoking is a very important risk factor, which we tend to miss when we take the history of risk factors in pancreatitis.
Yeah, Vikrant, go ahead.
Sir, the final diagnosis, I would like to slightly modify instead of putting acute necrotizing pancreatitis, I would like to consider infected pancreatic collection in week 18 of the illness. Etiology is unknown, complicated by sepsis and possibly sepsis without any features of GI bleed, gastric outlet obstruction, or jaundice.
Yeah. So I think we have.
Sorry. I would like to, can I just state my diagnosis and then Dr. Praveer can modify mine too? I would like to call it as acute pancreatitis, moderately severe acute pancreatitis, week 16, etiology unknown, complicated with infected wall of necrosis with sepsis, without features of GI bleed, gastric outflow obstruction, and jaundice. Now, I don't see why we need to put up anything else other than what you've already put up, just that you have to add on the week to it. What do you say, Dr. Praveer?
Yeah, I think that's okay.
Yeah, because you don't need to start off with an infected wall of necrosis straight on. You have to give the diagnosis of the etiology as well as the organ involvement as the first step and the week of involvement.
Absolutely. So can I
Dr.
just make
Jainta, please go ahead.
Yeah, can I make a small modification? Is that if we go by the history, in April when the patient had the first attack, the history suggested that there was shortness of breath for which the patient required ICU admission. So if that is the scenario, then probably we are dealing with a severe pancreatitis rather than moderately severe. I don't know, what is your take, sir, Sudipta sir? Or
was the ICU admission for 2 days or less than 2 days? And that was not very clear to me, actually. What is the short
okay.
period of ICU?
Okay.
That was for 6 days, sir. The ICU was for 6 days for breathlessness, but he recovered very well.
So then he comes under,
comes under initially a severe pancreatitis.
Absolutely, sir. Absolutely, sir.
So what I'm not sure is what this ICU admission means. So you can have a patient admitted in ICU without oxygen, maybe in some centers or so. So I think we need to be sure about whether there is organ dysfunction or not. So
Absolutely.
I think mild pancreatitis, moderately severe and severe, if we see according to Atlanta classification, the definition are very, very clear. So mild pancreatitis, we are not having any complication, we are not having any organ failure. Moderately severe pancreatitis, you need to have a transient organ failure. So if respiratory distress was there, it persisted for how long, and how much was the PO to FiO2 ratio. So that we need to have in place before we say that it's moderately severe and moderately severe or severe. So
absolutely.
I think we need more information to be very certain whether it was moderately severe or severe.
So probably this is the learning point for the residents, is that when you're taking a history of acute pancreatitis, and if you do not, obviously you will not have the P/F ratios, etc. So you have to be very specific on how many days the patient was on oxygen, or let's say these things has to come out in the history very clearly so that you can comment on whether it was a moderately severe or severe, as Professor has pointed out.
Sridhar, there are some questions in the chat box which probably we could take and then finish off as and when the thing progresses.
Any questions from here?
There's one which is saying that organ failure transient could be less than 48 hours or more than 48 hours to be classified as moderate to severe.
Yeah.
Any comments on that, sirs?
Transient organ failure is defined as less than 48 hours.
Yeah.
Yes.
So okay. So there is. I think most of these questions have been answered in the discussion. So one was, how many attacks of biliary pancreatitis can lead on to chronic pancreatitis if patient is not tackled appropriately? I think Jayanti madam has commented saying it seems more like acute on chronic pancreatitis with dull ache persisting between the two episodes. So whether it's a current complication or a fluid collection which is not known, or a carcinoma masquerading. And in epigastric mass, would one look for bimanual palpability and dilatability? Is Jayanti madam's comment. So I think, hello.
Yes.
Yeah.
Yeah, I think one obviously knows that ballotment is something which is specific for the renal mass. The point is, one, while you are eliciting the history or telling history in detail, one needs to point about these features so that one needs to be aware that these are the things that you have looked for while you're doing an examination.
Yeah. Okay. I think for the quantification and duration of alcohol for acute pancreatitis to occur, there is large amount of data, and I don't think we'll go into that. Should we add BISAP score in the diagnosis? Again, that would require the investigation, so we cannot really add it to the clinical diagnosis. What will we say severe on diagnosis and moderately severe at present? Now, is that something that you would want? I mean, severe at diagnosis and moderately severe at present. Hello. Ravi sir, Sudipta sir, Jayant, if you can just.
Sorry, I just couldn't get the question, Sridhar.
So the question is, if we actually say the diagnosis, whether it was severe at the initial diagnosis and moderately severe at present. I mean, is it a dynamic definition, or is it something that is, I mean, at the time of diagnosis that you're saying? Is what
I think the diagnosis of moderately severe and severe is primarily for prognostication of the individual and management triaging of the individual, whether the patient should be managed in the ward, in the ICU, that's about it. And there's nothing else beyond it, whether the patient with a severe disease should be managed in the ward or in the ICU setting, patient with moderately severe, what is the long-term prognosis of that individual. We all know that in severe acute pancreatitis, the mortality is higher in the first week of illness. In moderately severe, the morbidity is higher and the length of hospital stay is longer. That's all we know. Beyond it, I don't think so we can extrapolate much from that.
Okay.
Can I add just one more point? I think Sudipta sir, what Sridhar wanted to ask was that, will the final diagnosis when the resident writes, will he write it as moderately severe or severe as per the as in this case? In this situation, I believe that the diagnosis remains as single diagnosis. If you're talking about that same pancreatitis, which happened in April and now got complicated with a local complication, then the diagnosis should be acute necrotizing pancreatitis severe. If you're talking about severe or moderately severe, it does not change. And then talk about the complications.
So yeah, whether it's a dynamic definition or whether it's a definition that is taken at once. What
it is it's a dynamic, it's not dynamic, it's a diagnosis at one.
Yeah, okay. So I think
there's one more question, Sridhar.
Okay.
How can we comment on necrotizing without imaging? Is it okay at the point of history taking to say that patient has got acute severe necrotizing pancreatitis? Jayanta sir?
Sorry, sir.
I think let us be very clear about what necrosis means. So necrotizing is obviously a diagnosis of imaging. Clinically, you are just translating it. That is the possibility that the patient can be having. That's the reason I mentioned, in fact, infected pancreatic pancreatic fluid collection. So obviously necrosis you determine on imaging. Yeah,
absolutely, sir.
Okay. Should we go ahead with the investigations?
Yes. There is 2 questions from the audience over here. Can we just ask those questions? Do we have time?
Yeah, Jayanta, if you can go ahead.
There is one question where one asked that how do you, you need to explain sudden onset pain?
The second episode when sudden onset pain occurred. That is the question, I guess.
Yeah, I suppose. Yeah.
Okay. I think Vikrant and Gautam, if you can take that. How do you explain the sudden onset pain in this patient? I mean, a sudden onset 4-day pain that the patient is actually having.
So probably he might be having a second episode or a persisting pancreatic parenchymal inflammation during the present presentation. In addition to the infection, could be one thing that needs to be considered in this patient, sir. On top of the pancreatic collection, the parenchymal inflammation might also be present in this patient.
So Vikrant, this patient developed fever as well. So fever, maybe infection that possibly led to the occurrence of pain, or it's a new attack of pancreatitis that has happened. These are the 2 differentials that you can put forward.
Yeah. Yes.
I think the question probably stems with the word of sudden, is it?
Yeah.
I think the word of the adjective sudden is where the emphasis is. And when you say sudden in abdominal pain, there can be only 2 differentials, perforation and infarction.
Yeah, absolutely.
So I think that's a very good question here, Vikrant. That's a beautiful question, and we should appreciate that question. That when a person mentions sudden abdominal pain, there can be only 2 differentials. Either it's a perforation or an infarction. And in the setting of acute pancreatitis, you're looking at mesenteric venous thrombosis. So, that's a beautiful question, and I appreciate that question, really.
Yeah. So Vikrant, can you tell me what your sudden means?
I
What do you mean by
attributed it to
sudden when
the.
you mentioned sudden?
I attributed it initially to the infection, sir, and
No.
secondly the.
How
sir,
sudden was the pain?
Sir, it evolved a period of 1 day, sir. It's not that sudden.
Okay. Okay. I think we can.
Sorry, Vikrant.
Vikrant, one thing, once, because the patient was totally or almost asymptomatic with milder symptom in between for 4 months, that brings us to point that what is the natural history of development of word of necrosis or cirrhosis as a complication or an acute episode of acute pancreatitis. So is it a right time, 4 months? How many patients would develop after 4 months, 2 months, 3 months? I mean, that's a right thing we should discuss over here.
Vikrant,
Sir, I think the pancreatic fluid collection and the wall of necrosis, I think, will about a period of greater than 4 weeks, but I'm not sure since the sentinel event was 4 weeks, 4 months back. I'm not sure how in the current patient has avoided a period of 4 months. Either the patient might be having a small subclinical episodes which might have added to the collection which got infected.
Okay, so I think the question, Vikrant, was what is the natural history of a patient who develops a pseudocyst or a walled-off necrosis? Okay, that is the question. So what is the natural history of walled-off necrosis or pseudocyst?
Sir, acute pancreatic collection will evolve into pseudocyst after a period of 4 months, and acute necrotic collection after a period of 4 weeks will evolve into infected walled-off necrosis. Out of the 10% who develop, 20% who develop acute pancreatic collection, almost half of them will resolve spontaneously. Only the other half will develop into pancreatic pseudocyst. And also the similar findings in acute necrotizing pancreatitis, almost 60% will resolve without any treatment, and only the rest of the 40% will evolve into the walled-off necrosis. And 70% of the walled-off necrosis, 35 to 70% of the walled-off necrosis have a chance of developing the infected walled-off necrosis.
Can we go to the investigations?
Yes,
Yeah,
I think we can move forward.
Good morning, everyone. My name is Gautam. I'll be discussing the investigation part of this case.
So Gautam, you can tell me what investigations you want first.
Sir, I would like to have a basic CBC, LFT, RFT, and serum amylase and lipase.
Okay.
This is the CBC of the patient. From the left to right, it is sequenced in first admission, discharge, and the second admission investigations. During the first admission, there was a significant leukocytosis, neutrophilic predominant leukocytosis, and PCV also high with a value of 47. And during the discharge,
Sorry, I missed that. Could you say it again, please?
Yeah, go ahead.
During the course of hospital, the leukocytosis has come down and PCV have improved. And during the second admission, the patient again had increased total counts with similar neutrophilic leukocytosis.
Okay.
Yes.
No, before we go ahead, I think come to the prior slide. So what does this TLC mean to you?
Yes, sir. Generally, total counts in acute pancreatitis can rise either due to cysts or due to infections. Coming to the pancreatitis, the rise in total counts in first week, generally in the first 24 to 48 hours, we generally attribute it to the cysts component. And in case if total counts are being persistent even after 5 days of the presentation, we might think of infection process.
Okay. So here on the investigation done on 20th August, it shows 19,800 count, 80%, 85% polys. So what does that mean to you now at this point of time?
At this point, I would suspect infection, sir, at this point. Because in our examination, we found a epigastric mass, and he had a significant history of high-grade fever. So with that history and this finding, I would think first as infections, infection of pancreatic fluid collection.
So he has SIRS, right? He has leukocytosis. He has got tachycardia. He's got fever. He's got 2 out of the 3 criteria for SIRS.
Yes.
Yeah. So at this
That's
point,
all we can see.
you are expecting an infected pancreatic collection. This is what you want to say. Is that right?
Yes, sir.
Yeah.
During the first admission, the leukocytosis, I would attribute to this.
That was SIRS. Yeah.
Yes, sir.
Yeah.
Okay.
And coming to the amylase lipase, at present admission, the amylase level is 1100 and serum lipase is 890.
So
Why is that? Yes, sir.
Why is it still elevated?
Excuse me? Why is it still elevated? Sir, it can be either a new event of pancreatitis, sir, that can cause very high rise in amylase and lipase levels.
Or could it be that there is the fluid collection persistence? Fluid collection itself can also lead to a persistence in elevation of amylase and lipase. When you have a walled off necrosis or a pseudocyst, amylase and lipase can still be elevated after the first episode.
It can be elevated. Coming to the LFT part, during the first admission, patient had mild transaminitis with a very mild rise in the alkaline phosphatase. So at this point of time, with this picture of LFT, I would suspect a biliary pancreatitis. And during the discharge, the transaminitis has resolved and ALP came down. And during the second admission, there is no transaminitis with a very mild rise in the ALP.
So what is your pointers for a biliary pancreatitis in the first episode? Can you just elaborate a bit more in detail?
Yes, sir. In case of patient presenting with a pancreatitis, if the LFTs are abnormal, it is most 90% sensitivity that the patient is having a biliary etiology of a pancreatitis, sir.
Which parameters in the liver function test would you focus on?
I'd be focusing on transaminitis and ALP, sir, mostly for biliary pancreatitis.
So you'd focus on the ALT?
Transaminitis, SGPT. In transaminitis, SGPT, sir.
Yeah. Just for the sake of all residents, I have a problem with the word called transaminitis, because itis means inflammation. Transaminases are not organs. They do not get inflamed. So we should just avoid that word called transaminitis. It's just a misnomer. Yeah, so just again, transaminases, elevated transaminases, and yeah, AST, ALT elevation. And ALT more than 3 times upper limit of normal has shown to have a very high positive predictive value. ALT in a meta-analysis has shown that if the ALT elevations of more than 3 times upper limit of normal has almost a 95% positive predictive value of biliary pancreatitis. That's very good. So it has come down to normal. Yeah. Please proceed. Sorry.
Can I ask one question?
Just a point here. If you just have an isolated elevation of alkaline phosphatase, it may well be because of the pancreatic head edema compressing upon the bile duct causing the elevation. So that you have to remember. So it may not really indicate alkaline phosphatase elevation alone may not reflect biliary pancreatitis. Jayanta, you were saying something.
Yes, sir. I was about to make this point only. Yes, sir. Yes.
Go ahead.
There's actually one more question in the chat box, which says, do you require to do both amylase and lipase in all patients? What is the current guideline? Is lipase alone sufficient?
Yes. There's no guideline, but lipase alone is sufficient. You don't need to do both.
Because we think that it takes care of both early and late. So probably lipase would be probably the very ideal situation.
Yes.
With this patient.
Yeah, go ahead, please.
Yes. Coming to the renal function test, there are normal in both the admission periods.
Okay. Any other investigations?
I would like to do an etiological workup with fasting lipid profile. And the lipid profile, the total cholesterol and triglycerides are not within normal limits. The HDL is slightly on the lower levels. Rest of the parameters are normal.
So why are you doing this test, lipid profile?
So we need to rule out one of the common cause of pancreatitis is hypertriglyceridemia. If the values of triglycerides are 1000, then the etiology would be attributed to the hypertriglyceridemia.
Yeah, true.
At what level of triglycerides does the risk increase?
Risk increases beyond 500.
Absolutely, very good. So yeah, as the risk goes beyond 500, the risk increases. At 1000, it's at 5%. At 2000, it's 10 to 20%. Yes, very good.
So Deepto, can I add one here? So to all the residents, once you make a diagnosis, once you start investigating, first confirm diagnosis, then go to etiology. So primary investigation that way, that first you confirm what your diagnosis, then look at etiology. Right.
Okay. Next investigation.
One more point can I make regarding this triglyceride?
Yeah, go ahead.
Yeah, I think there are two important issues. One is that although there are multiple data and studies which suggest that probably the etiology does not affect the outcome in cases of acute pancreatitis, but there are some studies which have shown that hypertriglyceridemia induced pancreatitis probably have a much more severe course as compared to the other etiologies. This is one. And one more important point is that even if it is not hypertriglyceridemia to that level which will cause acute pancreatitis, but even a baseline high level of hypertriglyceridemia has been shown to have an adverse prognosis in patients with acute pancreatitis. Sudipto sir and Pravi sir for any comments, sir.
Yeah, Jan, there are two very large cohort studies done in the Scandinavian countries, which have shown that actually the risk starts to increase almost about, if I may be quoting wrong, so I don't want to quote this here, but it must be around 1.4 is the odds ratio, which was increasing beyond 200. So actually the risk starts to increase incrementally beyond 200. There are two very good Scandinavian studies,
absolutely,
very large studies from Scandinavian countries, which have shown that hypertriglyceridemia risk actually starts to increase beyond 200. Now, when you're talking of hypertriglyceridemia, one thing we have to remember is that not in the context of this particular patient, but any other patient, during the episode of acute pancreatitis, we may still find these levels to be low. It's after the recovery of acute pancreatitis, we have to again recheck these parameters of the patient, because sometimes during the episode of acute pancreatitis, the triglycerides may drop down and rise again once the patient recovers from the episode. Because when the patient is fasting, the levels might again drop down and again rise once the patient has started to go back to his normal diet.
Right, sir.
Yeah, please go ahead.
Coming to the next investigation, I would like serum calcium. Here, on both admissions, serum calcium level was normal. And next, inflammatory markers with the CRP, which is a high in the current admission and also in the old admission, which came down before the discharge. One most important thing is the procalcitonin, which was normal during the first admission. And here the procalcitonin level is 6.2, which is significant. Because generally the procalcitonin level can rise in acute pancreatitis even without infection, but beyond the 2.2 to 2.5 value, it signifies that there is an infection, ongoing infection. But the blood cultures were normal, and regarding the etiological workup, to rule out malignancy, CA99 and CEA were done, which which are in normal limits. So I would rule out hypercalcemic induced and malignancy induced pancreatitis with these investigations.
Any other investigation?
I'd like to have a plain X-ray, sir. X-ray chest and X-ray abdomen.
See, at this point of time, actually, Dr. Govind Makhadi had pointed a very, very important point. And what you need to tell me at this point of time, are you convinced about the diagnosis of acute pancreatitis with fluid collection?
Fluid collection might be, sir, but I'm convinced with acute pancreatitis infected with the perifluid collection.
So what is the criteria for diagnosis of acute pancreatitis?
For acute pancreatitis, the patient should have a typical pancreatic type of pain with rise in a serum amylase lipase levels 3 times upper limit of normal and with the radiological confirmations. Either any two of the three should be present to diagnose it as acute pancreatitis.
Okay, so I think even without an ultrasound imaging, you are convinced about the diagnosis of acute pancreatitis based upon the typical history and based upon the reports of amylase and lipase which are elevated. Is that right?
Yes, sir.
Yeah. So now the purpose of the cross-sectional imaging will primarily be, one, to look for etiology. Second is to look for complications. So these are the two reasons why you will need an imaging. Go ahead, please.
Okay. So again, what investigation do you want? I think sir has kind of pushed you in a particular direction.
Just one more point, Sridhar.
Yes, sir.
The point of making that is always to go simple. That acute pancreatitis, you want to do ultrasound, you want to do CT scan. So go straight rather than doing an X-ray, because X-ray is not going to add any value to you. You do X-ray for looking at chest infection, but they come later. So it's not about going slow, but this is what you do in outpatient every day. That in acute pancreatitis, you first do a cross-sectional imaging to look at how much is the damage caused by pancreatitis. Right. And other point that we have just 15 minutes to 20 minutes left, so we can hurry up slightly so that we go to management, which is so important. So we can skip all those investigations, but not necessary. We go to main investigations and then treatment.
Okay, so
I would like to go for a contrast enhanced CT of pancreas.
So this is the old CT of the abdomen.
This is a contrast enhanced CT of abdomen, which was showing bulky pancreas. And there is a hyperdense lesion noted in the D2 segments, probably calculus, passed out calculus.
So, okay, go ahead. I don't think we can be sure that it's calculus or some tablet or I don't know what it is. So go ahead.
Yeah, diverticulum with material.
Okay, so this is the August scan.
Yes, this is a MR abdomen which was showing a hyperintense lesion with a well-formed wall in the body and tail of a pancreas with hypointense collections noted within the fluid cavity, so probably signifying a necrosis or debris in the pancreas. So it would be a walled-off necrosis. My differential diagnosis would be a walled-off necrosis at this point.
Okay, so what will you do now?
So, because the patient had a significant history of fever and the imaging finding is a history of a walled-off necrosis, I would like to first quantify the amount of necrosis. If based on that, we can intervene whether we will go for a US-guided procedure for quantifying the necrosis for diagnosis EUS, and if necrotic part is greater, is if it is less than 10%, we can plan placing a plastic stent. If it is greater than
Gautam.
So how will you quantify the amount of necrosis within the world of necrosis? What imaging modality would you choose? Sorry?
Endoscopic ultrasound.
Well, we already have an MRI, and MRI is a very good test to demonstrate the amount of necrosis within the one. And I don't know what additional benefit an EUS will give in thing. The MRI is a very good test. You do an EUS only to do the procedure, not to quantify the amount of necrosis. What do you say, Dr. Praveer? I don't know.
Yeah, I think that's true. MR gives almost all the information that you'll be getting on EUS. Moreover, the purpose here is to pick up the extent of necrosis, to look for the number of collections that we have, and to decide upon the treatment modalities. So right now, what you are seeing is a collection in the lesser sac. So if you have collection in the paracolic region, then possibly you would have resorted to other measures rather than doing an endoscopic measure alone. So that's the purpose why you are doing an imaging. As far as extent of necrosis is concerned, I think it's very well delineated in MR. Yeah. So go ahead. What will you do in this case now?
So, I would like to do an. Can I go ahead? Can I go ahead?
Go ahead. Yeah, please go ahead.
Yes, sir. I would like to do a therapeutic procedure, sir, to drain the wall of necrosis.
What therapy?
With because it is close to the gastric wall, we can do an US guided gastrocystostomy, sir, with lumen opposing metallic stent, placing a lamps.
Yeah, so just tell me what will be the advantage of an EUS or endoscopic procedure compared to a percutaneous tube?
The advantage would be in US guided procedure, generally it is done when it is closer to the stomach wall or a duodenal wall, which is easily accessible. Sir. In case if it is away from the wall, we need to go for percutaneous procedures. And in case of a percutaneous procedure, we need to initially cannulate, and once the tract is formed, we need to dilate. So we need to wait for that, and after that only we.
Yeah, so see, what I want to know from you is that what are the distinct advantages of EUS guided or endoscopic intervention compared to a percutaneous drainage? I just need 2-3 points. They are well documented now in studies because a radiologist will tell you that he can do the job.
Vice versa, where do we place percutaneous intervention in the management of wounds?
Sir, I can't.
Okay, so fair enough. So I think the reason why you are intervening endoscopically or EUS guided are, one, it ensures an internal drainage. The patient is free of a percutaneous tube, one. Second, it has been shown in multiple studies that the chances of reintervention is more when you're doing a percutaneous drainage compared to a endoscopic drainage. So you can see a tube hanging outside in a patient. For him, moving with that tube again causes a lot of discomfort. So there is hardly any doubt that in patients with possibly pseudocyst, the EUS guided drainage is the way forward. So what the question was put forward, where will you do an percutaneous drainage?
When there is not, when the wall is not formed well enough, or when the necrosis is not fully evolved, probably we can consider percutaneous drainage, sir.
And also in unstable patients.
Unstable patients, when the endoscopic intervention is not possible in those patients, also percutaneous intervention can be.
Yeah, I think the collections which are distant from the GI tract, usually the paracolics, one. Unstable patient where patient cannot, you cannot take the patient up for an endoscopic drainage. So these are two important reasons, or a lot of necrotic debris, maybe more than 50% or 60%, where even you don't want to do an endoscopic necrosectomy. So those are the cases where possibly you may choose to do a percutaneous drainage.
And I think, sir, one more additional point that I'd like to make is that percutaneous drainage, with endoscopic drainage, we avoid the chances of an EPF development, development of external pancreatic fistula. So that we can avoid.
So go ahead.
Yes, sir.
You have some more slides here?
Yeah, I think I'll just show the US.
So you mentioned that you would do a drainage with a lumen opposing metal stent. This is what you said, and what you are showing is possibly again the deployment of a metal stent. So what I want to know is, suppose it is just a pseudocyst, do you have evidence at this point of time to say that the metal stent is better compared to a plastic?
No, sir. As of now, for pseudocyst management, only plastic stents are better, sir. And even we can use multiple plastic stents. In case of very large pseudocyst, only the metal stent will be useful, sir.
Do we have that evidence that large pseudocyst metal stent are better?
No, sir.
So I don't think that we have evidence to say that for pseudocyst metal stents are any way better. Can you just run through this video? And can you tell me that on EUS, what do you think is the extent of necrosis here?
Yes, sir. It is occupied. The hyperechoic region in the cyst cavity is occupying almost greater than 1/3 space of the cavity, sir. So probably 35%.
Yeah, so that will be anyone's guess. I think it's usually very difficult to say what is the extent of necrosis.
It is a very, very subjective issue.
Very subjective.
Until you have gross amount of necrotic material, I think 30% is a very, very vague number. And I don't know. We all say 30%, but until there is solid necrotic, I'm not sure about 30% in this particular case.
Absolutely, sir. So, and as for the for Gautam, as for the data suggests that, as Praveen Rai sir was pointing out, for pseudocyst, stent is something which is recommended. Even ESG clearly recommends that it is plastic stents that you have to place. Metal stents should be placed only if there is a research or a trial going on. This is point one. And point two, multiple studies and even meta-analysis recent has clearly suggested that plastic and metal both fare equally as far as the efficacy and the adverse events are concerned for one as well.
So if you look at the last study, which came in from Dr. Sham's group on metal versus plastic in WON per se, in fact, they have not shown a superiority of metal over plastic stents. And in fact, the adverse events in metal was slightly higher. Of course, that was primarily because they did not remove the stent at 3 weeks interval, which was supposed to have happened. Once they adjusted for that, the adverse events were almost similar in both the arms, which goes on to show probably we are still far away from understanding which is superior to that between plastic versus metal.
Probably, sir, the only advantage would be for the metal would be the procedure time. So if a sicker patient is there, probably you would like to just put a metal and come out immediately.
But common sense tells you that when you have large amount of necrosis, it's always, you are tempted to have a big size hole so that you assume that necrotic material will come out easily. It's common sense to believe that it should be the way to go.
Absolutely.
Yeah. So
a question to all the panelists, sir. Based on the US, which he had done in this situation, the amount of necrosis and the general condition of the patient with fever, spiking temperature, leukocytosis, what would be the approach on this patient? Would we probably intervene with an idea that you might require re-intervention at a later time? Or would we just do, because the studies have shown no big difference between plastic and metal stent, would we get away with a plastic stent in this patient?
So I think just comment on that. And before, as everyone has heard that there is again a confusion what to do in a world of pancreatic necrosis. So once that is the case, possibly we should be going by the guidelines. So what does the AGA review gastroenterology 2020 suggests? So what they have suggested that self-expanding metal stent, possibly the lumen opposing metal stent, are possibly superior to plastic stents for endoscopic transmural drainage of necrosis. This is what, again, the level of evidence will be weak here, but this is what is the recommendation by AGA review in gastroenterology. So as far as your question is concerned, what we do in our center, that if it's a clear pseudocyst, we can choose to place a plastic stent. But if there is necrosis, whatever extent it is, 10, 20, 30%, we end up placing a metal stent. This is what we do. And the reason why we do is, I think what is clear is when you have some amount of necrosis after drainage, what happens, many of these patients get infected, and then possibly you will need to do an endoscopic necrosectomy, which is better performed when you have a metal stent or a lumen opposing metal stent in place, compared to a plastic stent where you will need to go remove the stents, do the dilatation, and then do a necrosectomy. So if necrosectomy is in the cards, then lumen opposing metal stent may be the way forward.
That was also our thought, sir, that we might require a re-intervention in this patient. So I think it's all individual based. I think one need to probably take everything, the whole patient into consideration before we make a decision, because everything is costings. Being a corporate center, everything is a costing thing. So to do off with just plastic stent and face more complications later on would lean to a more definitive procedure like a metal stent.
Just to give a word of caution, whenever we place metal stents, we have to remember we have to remove it within 3 weeks.
That's right.
That is of paramount importance. Complications tend to increase after 3 weeks.
Yes, absolutely.
So I will just make a point here, but again, this is
of course, this is when you're using the Axios, not with this is primarily with the Axios.
Yeah,
this is for lambs basically, not for an AGI maybe.
Not for an AGI.
I think that's very important to recognize this. So I think the whole concern of GI bleed related to stent came from the gut article, which showed around 3 patients who had massive GI bleed. And this was because of lumen opposing metal stent, which is the hot Axios stent. We have done 60 patients till date with Nagi stent, and we removed all of these stents at a period of 3 months. Now this study is also published. That study has 45 patients. It's now online in Saudi Journal of Gastroenterology. 45 patients, stents removed at a period of 3 months, no bleeding in any patient. So what I think is possibly this hot Axios is a bit stiffer stent, with the flanges are a bit wide. It's 27 millimeter flanges. So the risk of erosion of the vessel is possibly more compared to a softer Nagi stent or the other stents which are in place. Yeah. So I think we are running short of time. Can you show what was done in this particular case?
Yes, sir.
Okay.
What we had done was put a lumen opposing metal stent in this patient.
And about 100 ml of purulent discharge was drained and sent for culture and sensitivity. The culture sensitivity identified Pseudomonas cutida as the organism, and appropriate antibiotic has been started based upon the culture sensitivity report. The patient was on follow-up for a period of 1 month. After 3 weeks, her stent was removed. He showed a significant improvement. He didn't require any necrosectomy after the stent was placed.
Dr. Sridhar?
Yeah. I think that's for Sir.
I think you had a couple of slides that are very pertinent regarding stents, infected management of infected stents. Because Dr. Govind said we can go up to 1240.
Okay.
So I think since we can go up 1240, I have just a few more important points to make.
Sure, sir.
So
wonderful, wonderful.
You chose to place a hot axial stent here. So do you think that you could have placed a cheaper stents that are available, Nagi stent or any other stent, or you think the hot axios does a better job? Because
point of contention, yes, sir. Point of contention. We could have used a cheaper stent, but we thought that he might require re-intervention, so we probably went ahead with an hot stent, thinking that he might require re-intervention.
Yeah, so the only point I'm trying to make is that suppose the patient is not having sufficient finances because it's a costly stent. So whatever you can achieve with a hot axios can well be achieved by the other stents that are available, because those all are fully covered stents, biflange stents, and cost is the hot axios is possibly 2 or 3 times costlier. You can do a necrosectomy with other stents as well, so that you can perfectly do. The only advantage of the hot axios is, I can tell you that if you are less experienced, even then you can do the drainage procedure well. So you just need to know the steps and you can perform the procedure. However, if you are deploying other stents, sometimes you may fail if you are doing only you have done only a few cases, then you can fail at the point of time. So that's the advantage of hot axial stent.
Small comment is we could have discussed the 3D MRCP picture because etiology is still not clear. So this is one point we could have been there. We could have discussed in the background. Second, hot Nagi is also now getting available. So we can go, the cost is again almost half.
So now, when will you remove this stent? You have deployed a hot axios.
Sir, after a period of 3 weeks, we assess for the, we do a pre-procedure MRCP check for any disconnected duct. If there is any, if there is no evidence of any disconnected duct, we can remove the hot axios system after a period of 3 weeks. But if there is any evidence of the pancreatic duct disconnection, probably the patient requires a pancreatic duct stenting and sphincterotomy. Following which the patient might be requiring a plastic stent insertion after removal of the metal stent, and the stent might be should be left in place for a much longer duration for the disconnected to heal.
Yeah, so you mentioned a term disconnected duct. So now that entity is there, disconnected pancreatic duct syndrome. So what is the definition of that?
Sir, definition of disconnected duct syndrome is when there is extravasation of the contrast from the main pancreatic duct during the ERCP procedure with then functioning pancreatic parenchyma distal to the obstruction and greater than 2 centimeters involvement of the pancreatic necrosis.
Absolutely. Yeah, you are correct.
Very good.
So you mentioned about doing an MRCP. So you think doing an MRCP gives you the whole information of ductal disruption, or you need some other imaging modality?
Vikrant,
MRCP, yes, sir. MRCP might not give the full information about the disconnected pancreatic duct, sir. Only at ERCP can we fully recognize the disconnected duct.
Yeah, so the gold standard for the diagnosis of disconnected pancreatic duct syndrome is an ERCP, which obviously is invasive, but that's the one which will give, which is considered the gold standard for diagnosis. Yeah.
Okay. Just a note on.
Sridhar, a couple of things. Can we discuss other aspect of pancreatitis? What is relevant in this patient, like other things other than only pseudocyst or water pancreatic necrosis, other aspects?
Yeah, I think nutrition is very, very important in this particular case. But how about this? Suppose in the first episode which he had presented to you, the first episode which was in April. So if he had presented to you in April, what would you have given him for nutrition and fluid? You have a diagnosis of pancreatitis made. So what would be your initial fluids and nutrition?
So the patient presented in the second day of illness, with a hemo concentration with a PC of 47%. Sorry, he requires aggressive fluid management with a bolus of 15 to 30 ml of 15 to 20 ml of IV bolus ringer lactate, followed by a maintenance of 1.5 to 3 ml per hour of ringer lactate, sir. Since he is also having a component of SIPs, we'll replace the fluid. And coming to the nutrition, once his pain begins to
First, let us look about fluids that you mentioned. Why do you want to give ringer lactate?
Sir, crystalloids are crystalloids, and among crystalloids, ringer lactate has shown better outcomes in among the fluids, because normal saline can cause hyperchloremic acidosis in these patients.
So any other reason? It can normal saline can cause hyperchloremic, and then what is the advantage of ringer lactate? Any other advantage?
Isoosmolar.
So it's considered to be more pH balanced compared to normal saline. One, it is assumed that it may have some anti-inflammatory action. However, the latest recommendation by AGA, they say that you can use either a ringer lactate or a normal saline. So these recommendations from different society do vary. From AGA 2018, they suggest that you can use either. This is what they suggest. However, in some other societies do suggest that ringer lactate may be preferred. So how much fluid? How much?
Sir, in mild pancreatitis, even if we give aggressive fluid management, also the outcomes 3.6 liters of fluid sequestration in mild pancreatitis and about 5.6 liters in moderate to severe pancreatitis was noted. So probably we can go ahead with the replacement of the same volume in these patients.
Yeah, so the guidelines do recommend an amount. Obviously, it has to be titrated. So the amount that is recommended is 5 to 10 ml per kg per hour. This is what is recommended. But obviously, you don't continue it for straight away 48 hours. You reassess the patient at a period of around 6 hours. And how do you reassess? What do you assess at 6 hours? If you give 5 to 10 ml per kg per hour, what are the parameters that you want to assess so that you don't overload this patient with fluid?
Urine output of at least 0.5 to 1 ml per hour with mean arterial pressure greater than 70 mm Hg, and we can monitor with IBC diameter as a.
So we use targeted fluid resuscitation based on urine output, mean arterial pressure, heart rate, stroke volume variation, intrathoracic blood volume,
and hematocrit.
And hematocrit. This is the IAP recommendation.
Yeah, so then you continue this resuscitation for a period of at least 24 to 48 hours. And assessing all these parameters which Dr. Sudipto has mentioned every 6 hours. So that obviously you need to consider the cardiac status of the patient, age of the patient, underlying comorbid illness. Those all factors need to be taken care of before you are transfusing aggressive fluid so that the patient doesn't go into heart failure. So what about nutrition? When do you start nutrition in patients with acute pancreatitis?
Can I just add one comment here, Dr. Praveer?
Absolutely, please.
Just to remember that in our country, most of the patients do not come within the golden period of resuscitation, that is the 12 to 24 hours. Most patients come after 24 hours or sometimes after 72 hours. So remember, when we're talking about this targeted goal-based approach of 5 to 10 ml of fluid, that fluid approach is only for those people who come in early. If you try to give that volume of fluid in a person who's coming late in the course of illness, will end up flooding the lungs. So just to remember this particular caveat, that this particular approach is applicable only to those group of individuals who come in very early in the course of acute pancreatitis and not to everyone.
And that early is within 48 hours. Up to 48 hours. Yeah. So about nutrition, when will you, a patient has come to, this patient had come to you in April, when will you start feeding this patient and what will you feed him?
Sir, the patient had moderately severe, possibly moderately severe pancreatitis. Sir, we should consider nutrition from day 2 to day 3 of presentation itself. Since the patient is in ICU, he might not be able to tolerate oral feeds. We should consider nasogastric or nasojejunal tube placement. And caloric requirement at the rate of 25 to 30 kilocalories and protein requirement of 1 to 1.5 grams per kg.
Okay, so I think let us be clear that if the patient is not vomiting profusely, there isn't severe abdominal pain because of which he cannot take fluid, the intake, the diet should be started as early as possible, which is within 24 hours you can start. About NJ or NG, it does not matter. There are now multiple studies to show that both have same results. It doesn't make any difference whether you are placing an NJ or an NG. So what diet will you suggest?
Sir, easily digestible low-fat diet or liquid diet we can suggest.
Yeah, any comment on that? What diet?
Low-fat diet.
Yeah, so this is what AGA recommends. However, the other societies don't recommend any specific diet. It's just low-fat, soft diet is what is recommended by AGA.
I think that diet recommendation came from ESPEN. So I think there is no hardcore evidence to suggest low-fat diet, but it's more of a consensus evidence that you give low-fat diet. Yeah, but low-fat, soft diet is what is recommended.
Yeah.
But as you said correctly, early oral feeding as much as tolerated, and if they're not tolerated, start off tube feeding.
And I think a very important point is that why are we stressing upon this oral early feed? The reason is that now there are clear studies to show that early enteral feeding decreases the risk of mortality and complications. So that is very, very clear. So this simple thing that early nutrition, early enteral feed will decrease the risk of mortality or the complications. So that's the reason why it's very, very important. So any comment about antibiotics?
Small feeding, if I can interrupt. I mean,
yes,
it has to be early, but very early feeding, which was there in the data of, I mean, the Annal of Surgery had an article initially. Very early feeding also may be avoided. There is a Dutch NEGM trial which has shown that even very early refeeding may have some disadvantages. So it's a be early. It can be as early as 24 hours, and as rest of the thing Dr. Praveer told.
Again, sir, I think it depends upon the severity of the pancreatitis. Mild cases you could start earlier. Moderate to severe cases, you probably need to delay it by at least 24 to 48 hours until the patient settles down for an early enteral feed.
Absolutely. That is, I think the Dutch study group that that Dr. Pawan was mentioning about, that rather than force feeding, probably early feeding in a sense, when the patient starts able to tolerate and all, at that point of time, the enteral feeding can be started. Here, I would like to reiterate one more fact is that when we talk about feeding, we don't talk about complete nutrition going through the enteral route, meaning thereby even aliquots of fluid or feed through the enteral route keeps the gut working. And as Dr. Praveer was pointing about, that decreases the gut translocation, that makes the gut barrier function, re-establishment of the gut barrier function, and probably that decreases the infective risk and the mortality risks later on.
So what you're talking about here, Jayant, is probably trophic feeding, giving off at least 500 kilocalories per day just to maintain the gut barrier function.
Just to maintain the gut, absolutely.
So trophic feeding is what we are looking at, and that's something which we can achieve by not giving high-calorie food. So it's just trophic feeding is just giving a little bit of food.
I'm having trouble connecting to the internet. It looks like a router issue.
Yeah, so I think I can see in chat box about injection statin. So I don't think we have sufficient evidence on this. Then I can see a question of any role of PERT. This is enzyme replacement therapy in acute pancreatitis. I think not in the initial phase. Later on, if you have a severe necrosis, these patients may have exocrine insufficiency at that point of time after testing, or even sometimes without testing. If you have sufficient symptoms, then you may consider, but not during the acute phase. Heparin role, Sudipto, you would like to answer that in the chat box, role of heparin?
Heparin as a prophylaxis, heparin for a hospitalized patient, yes. As a patient who's on the bedridden patient who's on low molecular heparin as a DVT prophylaxis, definitely yes. But beyond it, for treatment of splenic vein thrombosis in a patient who's got a splenic vein, an isolated splenic vein thrombosis in the setting of acute pancreatitis has not been shown to have much benefit unless there's extension of the thrombosis into either the portal vein or the superior mesenteric vein.
I think one more question that Sridhar has put up on the slide is pain management acute pancreatitis. This area is something which is completely still uncharted. Vikrant, what do you think should be the pain management protocol, or what would you like to give for pain management in acute pancreatitis?
So pain management, I would prefer the opioid analgesics as the first line, sir, followed by NSAIDs. In opioid, probably we can consider tramadol and pentazocine as a good first line management drugs, and followed by, if the patient is not responding, we can consider paracetamol IV infusion or other NSAIDs.
So probably you're talking about a WHO pain ladder pattern, right? So the data that suggests is there are very limited data on pain management in acute pancreatitis. This is point one. Yes, opioid analgesics are definitely better, has been proven better than the NSAIDs. There are two back-to-back RCTs, one from AIMS and one from our center, which has shown that AIMS did a study and they showed that pentazocine was better than diclofenac, and our center showed that diclofenac and tramadol both were working similar. We have one more RCT just about to be getting published, is that where we have shown, we have seen that buprenorphine, again an opioid analgesic, is better than NSAID for the pain management in acute pancreatitis. Sudipto sir and Praveer sir, for your comments, sir. Sir, you're muted.
Sir, there is one more question from Dr. Jayanti asking the role of antioxidants in the management of pain in acute pancreatitis.
I think there is no data to suggest that there is any role of antioxidants for pain management in acute pancreatitis. Definitely there is some data for chronic,
yes, sir.
But not
yes,
for
sir.
acute.
Yes, sir. Yes, sir. Yes, sir. Okay.
Praveer sir was saying something. Yes, sir.
Yeah, no, I think what you have mentioned rightly, and based on your studies and study from AIMS, those are the drugs that need to be considered for pain relief. So I think another thing actually which we haven't discussed, maybe just a word about that, is antibiotics in acute pancreatitis, which is often misused. So residents, any comment on that, Vikrant?
So during the first 5 days, the rise in the total counts is mostly like because of the CIRS response, and the patient might not benefit in the first 5 days with an antibiotics. If the patient is having persistent elevation during the second week, and in correlation with the rise in procalcitonin, rise in the CRP, probably we can consider an infective component, and probably might benefit of antibiotics if there is high clinical suspicion during the second week of illness.
No, Vikrant, what Pravi sir was asking is, let's say at day 5, day 6, the patient starts developing organ failure. Let's say at day 5, the patient starts a new onset organ failure. Will you be giving antibiotic or not?
Sir, empirically, we'll be starting antibiotics, sir.
So can I comment here, Jayant? And yesterday, I don't know whether you followed my presentation yesterday evening.
Yes, sir.
And
yes,
there was a lot of, I had this sort of interesting conversation yesterday. So if you look at the data that we have as of yet right now, and I'm going back to prophylactic antibiotics per se, there have been 3 definite meta-analyses which have looked at it. One was the Cochrane meta-analysis. 7 studies did not show any benefit. Then this Japanese meta-analysis came in from the Japanese pancreatitis study group. They included 6 meta-analyses, 6 studies, which included only imipenem as one of the drugs. And they showed benefit in mortality as well as infected pancreatic necrosis. Subsequently, a Chinese meta-analysis came in 2020, which showed no benefit. So amongst all the groups, I had enumerated all the societies. And amongst the societies, Japanese society is the only society which recommends use of prophylactic antibiotics within 72 hours. The Italian society says, do not use antibiotics. However, if the necrosis is more than 50%, you may consider antibiotics based on a case-to-case basis. So what you're alluding to, Jayant, is that in a situation where you have shock and sepsis, it's a case-to-case basis. If you are in Italy, you might use antibiotics. That's sort of a scenario. But other than that, none of the societies recommend use of antibiotics within the first week. Now, Besselink from Dutch pancreatitis study group clearly showed that the median of first infection starts off at 8th day. Day 8 is the first infectious complication starts off. And from then on, it's usually bacteremia, pneumonia. In the first, at the end of first week, from second week onwards, infected pancreatic necrosis comes into play. So it's the first week onwards, it's bacteremia, pneumonia. As towards the end of first week, towards the end of second week is the infected necrosis when it comes into play.
Absolutely.
So at 8th week onwards, we have definite evidence, the 8th day onwards, definite evidence that there is evidence of infection. But before that, it's anybody's guess whether you need to start antibiotics. And if a person is in shock and sepsis, I would leave it to a clinician's decision.
Right, sir.
I think we are very close to the closing the session, but can you have last question on etiology management after this episode is controlled? Maybe for 2-3 minutes to discuss that, and then we can close it.
Vikrant.
And I think, sir.
Sir, in this patient, since the patient was having elevated liver function test in the form of elevated ALT and hyperdense lesion within the second part of the duodenum, we should strongly consider the possibility of biliary pancreatitis in this patient. He might benefit from a cholecystectomy in this case, sir.
When?
I think
once the acute, since the patient is having acute necrotizing pancreatitis, we should wait for the necrosis. I mean the symptoms of the pancreatic necrosis to subside and the infection subside. Only then probably we can advise cholecystectomy in this patient.
So Vikrant, do you know of any evidence which suggests the timing of doing the cholecystectomy after an episode of necrotizing pancreatitis in gallstone-induced pancreatitis?
I'm not aware, sir.
So there's a recent gut paper which examined this particular instance, and the optimal timing of cholecystectomy after necrotizing biliary pancreatitis in absence of peripancreatic collections has been determined to be within 8 weeks after discharge.
That's the EPIC trial that sir is suggesting, and all residents should be knowing about it.
It's a very important landmark trial which has come into gut, and I think we should all be aware of it.
Right, sir.
I think we can close now because the program of medicine has started 1:30. So little time for lunch in between.
Just to interrupt,
last comment by
all the residents and of course others also are requested to join the pgigiupdate.com. That's the link that has been shared with you guys. So 1:30 sharp, we'll be starting these sessions. Dr. Govind, please.
I think thank you so very much, everyone, for this wonderful case discussion on acute pancreatitis and its complications. I think
Thank you, Dr. Govind, for giving us a chance to present this case. And I congratulate my residents to have done a good job on this case presentation. And thanks all the panelists on here, Dr. Samantha, Dr. Rai, Sutto, and Dr. Sridhar for all their contributions. Thank you so much.
Absolutely. I think we must all congratulate. We must all congratulate both Vikrant and Gautam.
Sir,
they did a wonderful job.
Yes,
you want to say something, Jayanta?
Yeah, sir, ma'am just wanted, can I just announce all the sessions that are upcoming for the PGI-GI update? The sessions are gastroenterologist and surgeons interface. The second session will be on, the next session is acute liver emergencies. And the final session, there is one more session on pancreatic injury, post-blunt abdominal trauma. And finally, the luminal emergencies. So these are the 4 sessions that are there, and there is an interesting quiz session after that. Thank you, sir.
Perfect.
Over to you, sir.
Yes, perfect. So thank you so very much, everyone. Dr. Ganesh, it's a wonderful case you chose from your institute, and Gautam and Vikrant did a wonderful job. I think we must thank Dr. Sudipto, Dr. Pravi Rai, Dr. Jayanta Samant, and Dr. Pavan Rawal, and Dr. Sridhar for taking this case through, discussing all important points which concerns a patient with acute pancreatitis. Thank you so very much, and I'm sure everybody got benefit. I must thank all the participants of this masterclass. I hope that they are useful to you, and we also want feedback that how better how do we make it better in terms of its academic quality. So we look forward to your feedbacks to be written to us on the same email, that's at the secretary@isg.org.in. If you can send your feedback, that will be wonderful, and we can incorporate. Our apology for certain echoes happened during the transmission today, but we'll try to take care that this doesn't happen in our next session. Before we close, let me announce the next masterclass will be on 17th of October. On 10th of October, that's the next Sunday, we are organizing Gastroenterology Young Masters, which is a unique program by ISG for residents, third-year residents. So this program is done in New Delhi, a physical program on next Sunday. So next Sunday, we will not have masterclass. So we will have a next masterclass, virtual masterclass on 17th of October. And the case will be a patient with dysphagia. But before we close, we need to request you to send your abstract for ISGCon 2022 or 2021. This is being held in Pune in February 2022. Last date of abstract submission is 15th of October. We just have 10 days left. So please do send your abstracts. Do send your paper for plenary session and also for Young Investigator Award session. For plenary and Young Investigator, we need your full paper, but otherwise you can submit any abstracts. And we need to hurry about that. It's just 10 more days left. Regarding all these masterclass, previous masterclass, the videos are uploaded on the ISG website. That is ISG library. You will find ISG library and all the videos are uploaded there. And also you can watch through YouTube. With this, we closed today's masterclass, and we request all of you to join the PGI-GI emergency course, which is going to start in half an hour from now. Till then, have a great day ahead. Thank you, everyone, and bye-bye.
Thank you. Thank you, sir. Thank you, sir.
Thank you.
Thank you, Dinesh. Thank you, Yogita, for organizing this meeting. Okay, bye-bye.
Thank you, sir.